السلام عليكم everybody. بسم الله الرحمن الرحيم وبه نستعين. I hope that you are in good health and prosperity. Today inshallah we will talk about the last part in the drug treatment of myocardial infarction. So the main goal of this lecture is to first to know what are the rationales behind the therapy of myocardial infarction as a revision of what we have covered last week or last presentation. Second, we have to know what are the basic pathophysiology which will lead to the formation of the thrombus. We have to know as well how we dissolve an already formed thrombus by drugs using known as thrombolytics. Also, we have to know how to prevent the formation of a thrombus by anticoagulants. We are going to know their different types and how they act, their mechanism of action. And lastly, we will talk about how we can prevent platelet aggregation by using antiplatelet drugs. We are going to discuss their different types and mechanisms. So these are the goals in revision of what we have covered in our last presentation. We have said that myocardial infarction is due to defect in the oxygen supply or oxygen demand, and this usually results in the necrosis or death of the myocardial tissue. We have classified myocardial infarction into two different types. The first is known as type 1 myocardial infarction, and the second is known as type 2 myocardial infarction. In type 1 myocardial infarction, we said that there is atherosclerosis of the coronary artery complicated with a thrombus. If the thrombus covers completely the diameter of the blood vessel or produce complete obstruction of blood flow, this will result in what's known as ST elevated myocardial infarction, or what we have called STEMI. If the block is not complete, partial block, thrombus will partially block the coronary artery. This will produce another type 1 myocardial infarction, which is known as non-ST elevated myocardial infarction or non-STEMI. In both cases, in type 1 myocardial infarction, we said the rationale of therapy, of course, is to remove or dissolve the thrombus. This is first, and to prevent the reformation of the thrombus. This is the rationale. This is logical. Also, in this type of myocardial infarction, we have to decrease the oxygen demand by different mechanisms, as we have said in the previous presentation, and we are going to mention it in brief. Type 2 myocardial infarction, on the other hand, there might be atherosclerosis or no atherosclerosis with no thrombus. There is no thrombus involved. Usually there is a disturbance between oxygen supply and the demand. Usually the demand is more than the supply for a long period of time. This type 2 myocardial infarction can be induced by cardiac causes, and cardiac causes can be different, can be arrhythmia like bradyarrhythmia and tachyarrhythmia. Also valvular disease can induce type 2 myocardial infarction, cardiac hypertrophy and acute heart failure. These are the cardiac causes. Type 2 myocardial infarction can be caused by non-cardiac causes like hypertensive crisis, like a shock or severe drop of blood pressure, like respiratory failure, like anemia, like critical illness. So we said that the rationale of therapy of type 2 myocardial infarction will be, of course, to treat the underlying cause. If the person is suffering from arrhythmia, we have to treat arrhythmia by using antiarrhythmic drugs. If the patient is suffering from acute heart failure, we have to treat acute heart failure, etc. Together with this treatment of underlying cause, we have to decrease the oxygen demand by using drugs which decreases the cardiac function. So this is revision what we have said in our last presentation. In our last presentation we spoke as well about the rationale for the pharmacological treatment of myocardial infarction, and we have said that there are four major measurements or four major lines we use in treatment of myocardial infarction. The first major line is to improve myocardial oxygen supply demand ratio. As we have said, myocardial infarction is due to defect imbalance between oxygen supply and oxygen demand. Usually the demand is more than the supply. So therefore, if we improve the myocardial oxygen supply demand ratio, we can prevent or treat myocardial infarction. This is done by either two ways, either to increase the oxygen supply or to decrease the oxygen demand. So this imbalance can be corrected by increasing the oxygen supply or decreasing the oxygen demand. Of course, we can increase the oxygen supply by different mechanisms, and we talked about nitrates or nitrites with calcium channel blockers, nifedipine-like calcium channel blocker. These drugs, they dilate the coronary arteries and they inhibit the vasospasm, and therefore they can increase oxygen supply. Of course, we can increase the oxygen supply in cases of STEMI and non-STEMI by dissolving the already formed thrombus using thrombolytics, as we will discuss in a few minutes. Also, we can increase the oxygen supply by decreasing coagulation or future formation of a thrombus by using anticoagulant drugs and by using antiplatelet drugs. Okay, so these are groups of drugs which are used to increase the oxygen supply. We spoke in details about the nitrates and calcium channel blocker, and today we'll speak about thrombolytics, we'll speak about anticoagulants, and we'll speak about drugs which inhibit platelet function. Second measurement is to decrease in myocardial oxygen demand, and in this case, of course, we have to decrease the work of the heart by decreasing the cardiac function, decreasing the heart rate, decreasing the cardiac contraction, and this can be achieved by beta blockers like propranolol, and it can be achieved by calcium channel blockers. We spoke about that in our last presentation. Also, we can decrease the oxygen demand by decreasing the afterload and the preload. Decreasing the afterload and the preload, as we have explained before, will decrease the tension on the ventricular walls and therefore will decrease the oxygen demand. Okay, so this is the second measure. We said that myocardial infarction usually is associated with very severe pain and anxiety. Therefore, we have to look for pain management, and in this case, the most famous drug used in this case is morphine-like drugs, which are known as opioids, which we'll discuss inshallah when we talk about centrally acting drugs. Morphine, besides treating pain induced by myocardial infarction, it can reduce anxiety, which is a usual common feature of myocardial infarction, and as well it will decrease the afterload. Morphine will decrease the afterload. Decreasing the afterload, as we have said, will decrease the oxygen demand. Therefore, morphine will produce three benefits. It treats pain associated with myocardial infarction, it decreases anxiety, and decreases myocardial oxygen demand through decreasing the afterload, as we will discuss inshallah when we talk about opioids. The third measurement in the treatment of myocardial infarction is to control any arrhythmia, and we have said that complication of myocardial infarction includes arrhythmia, because in myocardial infarction the necrotic tissue will act as the focus which will initiate ectopic activity. Therefore, sometimes we have to control heart rhythm by using specific antiarrhythmic drugs which will suppress already present arrhythmia, especially ventricular arrhythmia. And in this case, usually we use lidocaine, the local anesthetic, which we'll talk about, inshallah, when we talk about the antiarrhythmic drugs. So we can suppress arrhythmia by using lidocaine-like drugs. Also, we can prevent the development of arrhythmia. As we have said, arrhythmia can develop after myocardial infarction. In this case, we can prevent the development of arrhythmia by using beta blockers, like propranolol. Okay? Now, last measure is to inhibit cardiac remodeling. And we have said that cardiac remodeling takes place due to myocardial infarction by stimulating sympathetic activity and angiotensin II, renin-angiotensin II system. Therefore, by inhibiting sympathetic activity or inhibiting renin-angiotensin II system, we can decrease the cardiac remodeling. Okay? So these are the national of treatment, or we use different types of drugs according to the case, and in this case, a lot of drugs we have spoke about in the past, and we are going to speak about the rest. So the first group are drugs which are used to dissolve already formed thrombus, which is the main topic of today, are drugs which are used to dissolve already formed thrombus and to inhibit blood coagulation and to inhibit platelet aggregation. Okay? So this is the main drugs we are going to speak about today. Drugs which will dissolve a thrombus, drugs which will inhibit platelet aggregation, and drugs which inhibit blood coagulation. So as we know, thrombus formation, we know, and we have studied in physiology that thrombus is due to formation of a clot in a blood vessel. It might be arterial thrombosis in a main artery like coronary artery or cerebral artery, and it can take place in a venous, producing venous thrombosis. Of course, we are talking about arterial thrombosis. So arterial thrombosis usually in this case will result in obstruction. Arterial thrombosis in this case will result in obstruction of blood flow to the organ, for example to the heart, producing ischemic heart disease, as we have discussed before, or it can take place in cerebral blood vessel producing stroke. So how thrombus is formed? Thrombus is formed through two different stages, we can say. First, platelet activation and adhesion and aggregation. The second is the formation of clot. If we just imagine this is the blood vessel, normal blood vessel, with atherosclerotic plaque. As we can see, this is the lumen of the blood vessel, and the blood platelets, they are inactive and they circulate freely inside the plasma. When for any reason rupture takes place in the endothelium cover of the atherosclerotic plaque, this will result in release of many mediators which will cause platelet activation, adhesion, and aggregation at the site of injury. The mechanisms by which this takes place we will discuss in a few minutes. So the first step is the platelet adhesion, activation, and aggregation at the site of injury. This platelet, which is known as platelet plug, will cover the injured site, and it will be supported by fibrin clot. Fibrin clot will seal. This is the second stage. So the first stage is the platelet activation, adhesion, and aggregation, and second stage is the formation of fibrin clot. Fibrin will cover spaces between platelets, and it will give support to the platelet plug. Okay? How fibrin is formed? When endothelium cover of the atherosclerotic plate is exposed, this will lead to activation of different coagulation factors, including factor 10A. Factor 10A. This factor 10A, which is a vitamin K dependent factor, it will convert prothrombin into thrombin, which is factor 2A in the blood coagulation. Okay, so prothrombin under the effect of factor 10A, which requires vitamin K for its action, will be converted to thrombin. As we will see later, thrombin will be involved in the aggregation. It will increase the aggregation of platelets, as we will see later. Plus thrombin will convert fibrinogen, which is soluble in plasma, which is factor 1, fibrinogen, and it will convert it to insoluble fibrin. Converted into insoluble fibrin. Insoluble fibrin will form the clot, which will cover the platelet plug. Okay, so now the platelet plug is formed and it seals the injured part of the vessels. Okay, and of course once the thrombus is formed, it will obstruct blood flow in that vessel. So in this case, how we can treat a condition like that? How we can treat it? By three different mechanisms. First, by dissolving the fibrin clot. Second, by preventing the formation of fibrin. Third, by preventing platelet activation and aggregation. Okay, so we can prevent thrombus formation through three different mechanisms. First, by dissolving already formed thrombus. Second, by preventing formation of fibrin clot. Third, by preventing platelet aggregation and activation. So first is by dissolving already formed thrombus by using what's known as tissue plasminogen activator. Tissue plasminogen activator. This tissue plasminogen activator will act on an endogenous plasminogen which is present in the plasma and convert it to plasmin. A plasmin will work on the fibrin and convert it into soluble fibrin, dissolving the thrombus. Okay, so this is the first group. The first group, they dissolve the thrombus. How they do that? By activation of tissue plasminogen. And they are known as tissue plasminogen activator. Okay, they convert plasminogen into active plasmin. This plasmin will cause dissolving of the fibrin clot and convert insoluble fibrin to soluble fibrin, dissolving the fibrin clot, and therefore will dissolve the thrombus. These are known as thrombolytics, as we will see later. Thrombolytics, i.e. they cause lysis of the thrombus. Very famous examples of tissue plasminogen activator is alteplase. We'll take many examples like streptokinase, like urokinase, etc. So this is the first group, tissue plasminogen activator, and these are used to dissolve already formed thrombus. The second groups that are used to prevent the formation of a thrombus, to prevent clot formation, That's why they are known as anticoagulants. They are known as anticoagulants, as we will see later. These anticoagulants, they work by different mechanisms. The first, known as antithrombin 3 activators. Antithrombin 3 activators. Antithrombin 3, this is normally present in the plasma. Its function is to bind to thrombin, combines to thrombin and convert it into inactive complex. Okay, in this case it will prevent conversion of fibrinogen to fibrin. Okay, so antithrombin 3 activators, the most famous example like heparin, what does it do? It will bind with thrombin, preventing the formation of the clot. Of course, this will produce very fast effect, and usually they are given by intravenous route. Subcutaneous or intravenous route. The second group, there are drugs which will antagonize vitamin K. As we have said, vitamin K is essential in the activity of many coagulation factors. So drugs which antagonize vitamin K will antagonize coagulation factor. Most famous example is warfarin. Warfarin is vitamin K antagonist. It prevents the reduction of vitamin K, which is required for the activation of the coagulation factors. Therefore, warfarin will prevent the activity of coagulation factor and therefore will prevent the formation of thrombin. Of course, this effect usually is delayed because thrombin is usually present in the plasma and it takes a time before it can be depleted. Okay, so we'll discuss that in details in a few minutes. So this is the second anticoagulant, second group of anticoagulant. Third group of anticoagulant, drugs which directly antagonizes the factor 10A antagonist. This includes the Apixaban. This is a new anticoagulant groups. So in this case, we have discussed that we can prevent clot formation by using drugs which act at different steps of the clot formation, and they belong to different groups and they have different clinical application. Okay, so first we said we dissolve already thrombus. Second, we said drugs that prevent coagulation blood. Third are drugs which prevent platelet aggregation. Third, the group of drugs we are going to discuss today, inshallah, are drugs which prevents platelet aggregation. This includes these antiplatelet aggregation drugs. They belong to different group of drugs, as you will see, of different mechanism of action, and includes the most famous aspirin, tyrofibam, clopidogrel. Okay, so this is how thrombus is formed through platelet aggregation and clot formation. We said that this can be antagonized by different group of drugs, either that dissolve the thrombus or prevent the formation of the thrombus or prevents platelet aggregation. So the first group we are going to talk about are drugs which are used to dissolve already formed thrombus, which are known as thrombolytics. So the first group are used to dissolve already formed thrombus, and they are known as thrombolytics. Lytics means they induce lysis of the thrombus. This includes very famous examples. The very oldest is known as streptokinase. Streptokinase is obtained from bacteria, and of course, if it is a bacteria, bacterial protein can, if second exposure, can trigger antigen-antibody reaction, and can trigger allergic reaction, and in some people they can cause anaphylactic shock. Streptokinase is obtained from a bacterial source, and therefore it is antigenic. Its use is limited and can be used only once. It cannot be repeated. Why? Because second exposure usually will result antigen-antibody reaction, and it can result in anaphylactic shock. Second drug, oldest as well, urokinase, which is a urokinase. It is a human source obtained from a human, and still used in some country because it is cheaper than the new drugs which are known as tissue plasminogen activators. These drugs, they activate tissue plasminogen, as we said, and therefore they will increase conversion of plasminogen to plasmine, and plasmine will cause lysis of the fibrin clot, and this will lead to dissolving of the thrombus. The second group example, alteplase, most famous, alteplase. This is obtained from recombinant, a human plasminogen activator. by recombinant technology. Alteplase gene is the human gene is inserted into bacteria which starts producing these drugs. This is known as recombined human plasminogen activator. So alteplase is another example of thrombolytic drugs. Retiplase as well, and tenecteplase. Tenecteplase, this is usually it is muted from a human tissue plasminogen activator. It has a faster onset and longer duration of action. It acts fast and long. So thrombolytics, they have many clinical applications. First, in the treatment of acute treatment of STEMI or ST elevated myocardial infarction when percutaneous coronary intervention is not available. And usually in this case they should be given before the passing 24 hours. After 24 hours they become non-effective. So they should be, because in that case infarction will be too large and it will be useless. So in this case they are used and they should be given as soon as possible. Usually better results are obtained if they are given before the passing 3 hours after thrombosis. Usually in this case, in the treatment of STEMI, they are used with other anticoagulants like unfractionated heparin or low molecular weight heparin. So they are used together. We use tissue plasminogen activator like alteplase plus heparin, whether it is unfractionated heparin or low molecular weight heparin, as we will discuss in a few minutes. Okay? Now, third use in the treatment of acute stroke. This is very common. The same thing. The faster they are given, the better are the results. They have very rare use in pulmonary embolism and acute deep venous thrombosis. Very rarely, because there are other better choices. Okay? Thrombolytic drugs, the major side effect is bleeding, because they prevent formation of the fibrin clot. So a major side effect is bleeding, and therefore they are contraindicated in conditions where there is suspected bleedings, like in cases of active bleeding, like suspected aortic dissection, like bleeding diathesis, وكذلك when there is high risk of intracranial hemorrhage. Okay, so this is the first group which are used, they are known as thrombolytics. Thrombolytics, we said that they are used to dissolve already formed. The second group we are going to talk about are drugs which are used to prevent formation of new thrombus, and these are the anticoagulants and what are known as blood thinners. These drugs, as we have said, they prevent the formation of the fibrin clot by acting through different mechanisms. The first and most famous are the antithrombin 3 activators. As we have said, this group will activate endogenous antithrombin 3, which will bind or combine with thrombin in activating thrombin. This includes the most famous example, heparin. Heparin, as we know, it is naturally occurring in the body and present in the mast cells and the basophils of the blood. Heparin, commercially or pharmaceutical preparation, includes unfractionated heparin, which is obtained from animal sources, and also another heparins, synthetic heparins like enoxaparin, like dalteparin, like tinzaparin, which are low molecular weight heparins. These drugs, they have greater bioavailability and longer duration of action. Fondaparinux is another example of small synthetic drug that contains only the biologically active pentasaccharide which is present in the unfractionated and low molecular weight heparins. Okay? The heparin, they have very fast anticoagulant activity. When they are given, they produce very fast effect within minutes. Why? Because immediately they will activate endogenous antithrombin 3, and this antithrombin 3 will antagonize thrombin by binding with thrombin, converting it into inactive complex, and also it will antagonize factor 10A, preventing the formation of thrombin. And the most famous example of these, their uses, they are used in subcutaneous injection or intravenous infusion, especially in acute MI, and usually in this case they are given with antithrombotic or thrombolytics. Also, they are used in deep venous thrombosis and pulmonary embolism. Okay, so this is the first heparin. The most famous side effect of heparin, because it is an anticoagulant, is bleeding. So it is very common side effect, or major side effect is the bleeding. In case an overdose of heparin, the antidote usually is protamine sulfate. Heparin, as we know, it is highly acidic, and protamine will interact chemically with heparin, preventing its action. This we have described before as a chemical antagonism. Chemical antagonism, that means both drugs, they react with each other and each will antagonize the effect of the other drug. So usually protamine sulfate is very effective in preventing bleeding due to unfractionated heparin. They have low activity against bleeding induced by low molecular weight heparins. Okay, so this is the first group. They are antithrombin 3 activators. Antithrombin 3 activators, and most famous example is heparin, and usually it is used in acute cases of acute myocardial infarction together with thrombolytics, and also it is used for other venous thrombosis like deep venous thrombosis and pulmonary embolism. The second group in the anticoagulants, there are vitamin K antagonists, which antagonizes vitamin K, and vitamin K, as we said, it is important for the activation of many coagulation factors. And the most famous example is warfarin. We have to speak about the kinetic of warfarin, because warfarin, it has very special kinetic where it is highly lipid soluble and highly binded to plasma protein. So therefore we would expect only 1% is present free and available for biological action. So we expect that warfarin, any drug which would displace warfarin from its binding site, it will increase its toxicity. Also, warfarin is metabolized by oxidation by the cytochrome B450 enzymes, and therefore we would expect that its metabolism will be affected by drugs which are either activators of this enzyme or inhibitors of these enzymes. For example, carbamazepine, the anti-epileptic drug, will increase the activity of cytochrome B450 enzyme, therefore will increase the elimination of warfarin, and therefore will decrease its anticoagulant effect. Cimetidine, on the other hand, is inhibitor of this enzyme, and therefore it will inhibit the elimination of warfarin, and therefore it will increase its toxicity. So inhibition vitamin K epoxide reductase. This enzyme is essential for the activation of vitamin K, and vitamin K activation is necessary for the activity of many coagulation factors like thrombin, like factor 7, factor 9, and factor 10. Therefore, inhibition of vitamin K synthesis will result in inhibition of this coagulation factor and therefore will result in anticoagulant effect. We have to point out that this action usually is not fast, it will be delayed. Why it is delayed? Because the coagulation factor already present in the plasma, warfarin will inhibit the new synthesis of this coagulation factor. Therefore, it will not affect the coagulation factor which are already present in the plasma. Therefore, warfarin, it will have a slow onset of action. Action will appear only after the depletion of this coagulation factor from the plasma. At the same time, if we stop warfarin use, in this case, anticoagulant effect will continue for a certain period of time for the same reason, because time is needed for the synthesis of this coagulation factor. So stopping of warfarin will not end its anticoagulant effect. It will take time before a new coagulation factor are synthesized. Okay, so these are the mechanisms of action of warfarin. Warfarin usually it is used orally in treatment of different types of venous thrombosis and pulmonary embolism, where it is given as a prophylaxis and as well as a treatment of deep venous thrombosis and pulmonary embolism. Also, warfarin is drug of choice in thromboembolic complication associated with atrial fibrillation. Usually atrial fibrillation results in thromboembolic complication. In this case, warfarin is given as a prophylaxis against thromboembolic complication which is associated with atrial fibrillation. Okay, so this is the second group, vitamin K antagonist. Warfarin, they inhibit the coagulation factors by inhibiting vitamin K activation, and they have very important clinical application in prophylaxis and treatment of different venous thrombosis. Of course, major side effects of warfarin is bleeding. In this case, if we have given for any reason a higher dose of warfarin and we want to stop the bleeding due to warfarin, if we want an immediate effect, in this case we have to give fresh plasma. Fresh plasma. Why fresh plasma? Because fresh plasma contains all the coagulation factors. Therefore, it will prevent bleeding due to warfarin use. Okay? So if an immediate action is required to stop bleeding due to warfarin, we have to give fresh plasma. For a delayed action, we can give vitamin K. We can give vitamin K. So the antagonist of warfarin will be vitamin K. Of course, a time will be taken for vitamin K to produce, to stop bleeding. Why? Because it takes a time for the synthesis of new coagulation factors which are inhibited by warfarin. So this is the second group, vitamin K antagonist, and we have very important one example, which is warfarin. Third groups, there are drugs which antagonizes factor 10A or factor 10A antagonist, and we have said that factor 10A is essential for the conversion of prothrombin to thrombin. Therefore, if we block or antagonize the factor 10A in this case, we will block the formation of thrombin, and thrombin, as we have said, it has dual effect. It will increase the platelet aggregation, and as well it will convert fibrinogen to fibrin, and fibrin, insoluble fibrin, will form the fibrin clot. Therefore, if we antagonize vitamin factor 10A, in this case, no thrombin will be formed, and therefore will produce anticoagulant effect. Most famous examples are Apixaban, Indoxaban, Fondaparinux, and Rivaroxaban. Okay, so these drugs, they act, as we said, by reversibly blocking the activity of a clotting factor 10A. therefore preventing formation of the clot by preventing thrombin formation. And they are like warfarin, they are used for deep venous thrombosis and pulmonary embolism, and also they are used to reduce the risk of stroke embolism in people with atrial fibrillation. So they are used for venous thrombosis, pulmonary embolism, and to prevent stroke and embolism in people who are suffering from arterial fibrillation. So they are given by the oral route. So this is the second group of drugs which are used to prevent the formation of new thrombus. They are used for the treatment of arterial thrombosis, for example heparin, which is also used for the treatment of venous thrombosis. Warfarin is mostly for venous thrombosis. Factor Xa antagonist mostly for venous thrombosis, pulmonary embolism, and to prevent the risk of stroke embolism in cases of people suffering from atrial fibrillation. Platelet aggregation. As we have said before, platelet aggregation requires two steps. How platelets are aggregated in order to understand the mechanisms by which antiplatelets will prevent aggregation of platelets. So how this happens, if we just imagine this is the platelet. Platelet contains different receptors. First are the protease activator receptors, protease activator receptor type 1, and this protease activated receptor type 1, there are receptors selected for thrombin, and thrombin, we have said before, it is produced by the coagulation factor 10A. Okay, this is the first receptor. The platelet also contains another purinergic receptors known as B2Y12 purinergic receptors. Okay, these purinergic receptors, they are receptors selected for adenosine diphosphate. So adenosine diphosphate will bind to these purinergic receptors. Okay, the platelet as well, it contains specific thromboxane A2 receptor. Thromboxane A2, as we know, is the product of prostaglandin metabolism, and it is pro-aggregatory and vasoconstrictor, as we will see inshallah later when we talk about local hormones or local autocoids. Okay, so also the platelets contains another type of receptors that are known as glycoprotein receptors type 2B and type 3A. Okay, glycoprotein type 2B and type 3A. These type of receptors, usually when the platelet is not activated, they are inert. They are not a site of binding to anything. Okay, now they are inactive. These receptors, they are inactive. Okay, once thromboxane A2 or thrombin or adenosine diphosphate, of course thromboxane A2 is produced by the platelet. Thrombin, as we have said, produced by the factor 10A through the conversion of prothrombin to thrombin, and adenosine diphosphate is produced by the endothelial cells, the injured endothelial cells, adenosine diphosphate. Once adenosine diphosphate or thromboxane A2 or thrombin binds to their receptors, in this case the glycoprotein receptors will be activated. They become active. They become active to receive binding with fibrinogen. Okay, so as we can see now, once this agonist binds to the receptor, the glycoprotein receptors binding site will be released, and this glycoprotein will be available for binding with fibrinogen. This is a fibrinogen molecule. Okay, so in this case fibrinogen will bind with the glycoprotein receptors. Okay, So, very beginning, receptors, the platelet is inactive. When it is inactive, the glycoprotein receptors, they are inactive, they cannot bind to any fibrinogen, but once different agonists binds to their receptors, they change the configuration of these glycoprotein receptors, they become available to binding with fibrinogen. Once fibrinogen binds to this platelet, it can cross-bridge with other platelets. It can cross-bridge with other platelets. As you can see, we started with one platelet, binded with 4 different molecules of fibrinogen. Each molecule of fibrinogen can bind with another platelet, with another glycoprotein receptors of another platelet. This will result in platelet aggregation. This will result in platelet aggregation. As you can see now, we started with an inert platelet, and an inert platelet where there is no platelet aggregation floating freely in the plasma. Once this agonist binds to the receptor, when they are released for any reason, they will change the configuration of the glycoprotein receptor, which becomes available for fibrinogen molecule, fibrinogen which is normally floating in the plasma as well. Fibrinogen will bind to these glycoprotein receptors, and this fibrinogen can bind to several platelets and therefore producing platelet aggregation. Okay, so as we have said, platelets first they are activated and then they are aggregated. Aggregation, of course, will result in formation of the platelet thrombus. Okay, now, so how we can prevent platelet aggregation? We can do that by either antagonizing. So we can antagonize thromboxane effect through the use of aspirin. Aspirin is well known COX-1 inhibitor. Aspirin inhibits cyclooxygenase 1. This cyclooxygenase 1 is responsible for the synthesis of thromboxane A2. Therefore, by inhibiting COX-1, which is cyclooxygenase 1 will be inhibited, thromboxane synthesis will not be there, and therefore no activation of the thromboxane A2 receptor. So this is the first antiplatelet aggregation drugs, aspirin-like drugs. The second group, there are drugs which block adenosine diphosphate receptors, and these include the clopidogrel, most famous, clopidogrel, and ticlopidine. These both, they are antagonists, they block adenosine diphosphate receptor, Voraxabar, this blocks thrombin receptor, therefore they are antagonists at the thrombin receptors. Okay? The fourth group, they act by blocking the glycoprotein binding sites, glycoprotein 2B and 3A receptor. They block glycoprotein 2B and 3A receptors. Abciximab, antithrombin. These are glycoprotein 2B and 3A inhibitor. Okay, so anticoagulants, they act by different mechanism, either by blocking synthesis of thromboxane A2, like aspirin-like drugs, or blocking the ADP receptors, like clopidogrel, or blocking thrombin receptors, and most famous example for Abciximab, or by blocking the glycoprotein binding site. If we go to the therapeutic application of antiplatelets, they are used either alone as a single therapy, And the most famous example, of course, aspirin. As we said, aspirin will prevent the synthesis of thromboxane A2 and therefore will prevent platelet aggregation. And they are used, usually aspirin is given after recovery from myocardial infarction to prevent any further formation of a thrombus due to myocardial infarction. Okay. Also, aspirin is used as a prophylactic to prevent transient ischemic attack. Transient ischemic attacks usually they are of very mild ischemic attack or ischemic stroke. Ischemic stroke, which thrombus which can take place in the brain. So aspirin in low doses, not in normal analgesic dose. Usually it is only 70 to 80 milligrams usually a day taken. It can prevent any further formation of a thrombus after an acute attack of myocardial infarction, and also it can prevent transient ischemic attacks with mild attack of ischemia, and it can prevent as well ischemic stroke. Single therapy, clopidogrel as well, very famous. Clopidogrel is used to prevent transient ischemic attacks and as well ischemic stroke which can take place due to ischemia of the brain. Okay, so clopidogrel is another example. We have to know. I have to mention here that clopidogrel metabolism is genetically determined. Clopidogrel, it is a prodrug. It should be metabolized by cytochrome B450 enzyme before it can produce any action. Some people they are deficient of this enzyme and therefore they produce no conversion of clopidogrel to the active drug and therefore it can produce no action in them. So clopidogrel is very famous in that its metabolism is genetically determined. The third example, Abciximab, and usually they are they use to prevent restenosis after coronary angioplasty, and also they are used for a short period of time in acute coronary syndromes like in cases of unstable angina and non-Q-wave acute myocardial infarction. It's common practice with antiplatelets they are given in combination therapy. Usually dual antiplatelet therapy is known as dual antiplatelet therapy or DAPT. And the most famous combination is the use of aspirin plus clopidogrel. And the most famous combination is the use of aspirin with clopidogrel. And usually these drugs are given within 24 hours from a minor ischemic stroke or high risk transient ischemic attack and should not be continued more than 21 days because this combination can result in bleeding. So they should be given as early as possible after exposure to minor ischemic stroke to prevent any further ischemic stroke, or in cases of high risk transient ischemic attack, and treatment should not be continued more than 20 to 21 days because of the possibility of bleeding. Also, it is used for long period of time in treatment to prevent thrombosis in patients who are replaced. They have coronary artery stent after placement of a coronary artery stent. In this case, this combination they are given for a long period of time to prevent thrombosis in patient after placement of coronary artery stent. Second combination, which is very common, is aspirin and dipyridamole. We didn't speak about dipyridamole. Dipyridamole is phosphodiesterase inhibitor. It will increase the cyclic AMP and it will prevent platelet aggregation therefore. Okay, now so this is a common combination, aspirin and dipyridamole, and usually they are used to prevent secondary prevention of ischemic stroke. They are used to prevent secondary attack of ischemic stroke. Okay. Third combination is the use of warfarin and dipyridamole, and usually they are used to prevent thrombosis in people who have aberration cardiac valve replacement. Okay, very common combination, warfarin and dipyridamole. They are used to prevent the thrombosis and those with cardiac valve replacement. Okay, so these are the clinical application of antiplatelets. They are used alone and to prevent a future attack of myocardial infarction and also ischemic stroke, and they are used as well to prevent thrombus formation in different clinical situations. Okay, so by this we have finished the different drugs which are either produces lysis of the thrombus or prevent the formation of the thrombus or prevent platelet aggregation. So in summary, we can say that we have talked about types of myocardial infarction, type 1, where there is atherosclerosis and thrombus, and usually this type is treated by dissolving the thrombus by thrombolytic and preventing the formation of the thrombus by anticoagulant and by decreasing the oxygen demand through the use of beta blockers, calcium channel blockers, and nitrates, and we have explained how these act. Type 2 اللي هو قلنا there is no thrombus but there is a higher oxygen demand which exceeds the supply, and usually this is due to either cardiac causes or non-cardiac causes. We said that we have to treat the underlying cause, and as well we decrease the oxygen demand according to the condition or according to the cause. We spoke about thrombolytics, which are tissue plasminogen activator. They activate plasminogen and convert it to plasmin, and as we have said, plasmin will dissolve the insoluble fibrin clot. They are used in acute treatment of STEMI, وكذلك they are used in acute stroke. Okay. The third group, they are the anticoagulants, and there are three different groups. We have spoken about antithrombin 3 activators like heparin, and heparin, as we have said, it is used together with thrombolytics in acute myocardial infarction. It is also used in deep venous thrombosis and pulmonary embolism. We spoke about vitamin K antagonists, especially warfarin, and it is taken orally, and the vitamin K antagonist will prevent synthesis of many vitamin K dependent coagulation factor, and these that are used, warfarin is used orally in treatment of deep venous thrombosis and pulmonary embolism, and as well to prevent thromboembolic complication resulted from atrial fibrillation. The same thing goes to factor 10 antagonist, Apixaban, and it is the same use like warfarin. We talked about antiplatelet aggregation, drugs which prevent platelet aggregation. The first group, they are thromboxane A2 synthesis inhibitor, and these are the most famous example, aspirin in low doses, and aspirin will prevent further myocardial infarction, and we have explained why, and also it is used to prevent transient ischemic attacks and ischemic stroke. Adenosine diphosphate antagonists like Clopidogrel, they are used to prevent transient ischemic attacks and also to prevent ischemic stroke. Glycoprotein IIB inhibitors like Abciximab will prevent restenosis after coronary angioplasty and are used short period of time in acute coronary syndrome like unstable angina and non-Q wave acute myocardial infarction. We talked about the dual therapy with different antiplatelet drugs like the combination of aspirin and Clopidogrel, like the combination of aspirin and Clopidogrel, the combination of aspirin and dipyridamole, a combination of warfarin and dipyridamole. So these are, in summary, the drugs which are used to as thrombolytics, anticoagulants, and antiplatelet aggregation, their mechanism of action and clinical application. In our next presentation, inshallah, we will talk about drug treatment. We'll start talking about drug treatment of heart failure. Until then, I would like to thank you very much for your attention. Please don't forget to subscribe to my channel. I wish you all success, happiness, and prosperity. Wassalamu alaikum wa rahmatullah wa barakatuh.